Hi and welcome to Lessons from the Grand Rounds. So in this video we are going to discuss about basics and some important points about ICANS. So let's go to a clinical case first. 37-year-old male, primary diagnosis of multiple myeloma, first line of therapy VRD, progressive disease, refractory to the first line. Then we shifted him to DARA KPD, again refractory. Patient is enrolled into the teclistamab trial. He was off therapy for a month because of enrolling and the other financial issues. Patient receives step up dose 1 and 2 of teclistamab, and post receiving step up dose 2 at the night patient develops mild tremors, some confusion, and the I score is 8 out of 10. So this is a case of grade 1 ICANS secondary to teclistamab. ICANS is basically immune effector cell neurotoxicity syndrome, associated neurotoxicity syndrome, and this was classically described after CAR T cell therapy. And the incidence post CAR T cell therapy is approximately 20 to 60%. So 2 to 6 out of 10 patients experience some the other form of ICANS, and severe ICANS, which is grade 3 or more, is seen in 12 to 30% of the patients. So the median time when ICANS um, is seen is 5 days after CAR T cell infusion. There is a term of delayed ICANS which is seen in 10% of the patient, which is seen after 3 weeks post CAR T cell infusion. So CAR T cell therapy, teclistamab, which is a bispecific T cell engager in relapsed refractory myeloma, similarly elranatamab, epcoritamab, and glofitamab for relapsed refractory myeloma, and blinatumomab, which is again a bispecific for relapsed BALL. These are the 4 settings where we see ICANS. Is there a proper, fully understood mechanism for ICANS? So there has not been uh, proper evidence of the mechanism of ICANS. It is believed that there is a pro-inflammatory cytokine which is secreted by the macrophages and the monocyte, which causes increase in the vascular permeability and endothelial activation and eventually breakdown of the blood-brain barrier, which leads to cerebral edema and these symptoms. So there is no evidence of direct effect of CAR T cells leading to ICANS. So what exactly are the symptomatology for these patients? As described, the symptoms commonly are confusion, mild tremors, and apart from that agitated behavior, and in severe forms will be convulsions. And one of the most prominent signs would be hesitancy of speech and change in the handwriting. So that is why the handwriting is one of the component of I score, which we'll be discussing. And the speech parameter could be as impaired as a aphasia, and the most fatal or the deadly complication of ICANS is status epilepticus and encephalopathy and cerebral edema, which usually requires ICU care. So ICANS is a clinical diagnosis. We rarely require MRI or lumbar puncture or CSF analysis, but if we do to rule out infections. So let's discuss about ICE score. So ICE is basically immune effector cell encephalopathy score. It is a 10-point score. So it is available in MDCal. It is also in the Cartox app, which we commonly use to uh, calculate ICE score. ICE score is started using after day 0, that is on the day of infusion, till the patient is available, and then we do it at least twice a day. So what are components of I-score? I-score checks your orientation. So orientation to year, month, city, and hospital. The second component is naming. So we ask the patient to name 3 objects. The third component is following commands. We can give simple, ask the patient to follow simple commands. The fourth component is writing. So we ask them to write in their native language. And the fifth component is attention, which we check by asking the patient to subtract 10 from 100 subsequently. So this is the I score, and this is one of the components to also grade the severity of ICANS. So as I said, we check twice daily the I score after the day of infusion. So based on this, we grade the ICANS. So ICANS is graded as 1, 2, 3, 4. And what are the parameters when we grade ICANS is I score, motor findings, and also the level of consciousness and the imaging findings and the EEG findings. So, what are the factors which predict severe ICANS? So, the first point is first risk factor for a severe ICANS is high disease burden. The second thing is low platelet count. And the third thing is development of early or late concurrent CRS, that is cytokine release syndrome. So let's talk about the overall grades. So only important points. Grade 3 you will see convulsions, and you'll also see findings, imaging findings of cerebral edema in grade 3, and in grade 4 you will have status epilepticus and diffuse cerebral edema on neural imaging. So for grade 1, in a very short form, grade 1 you have supportive management and twice daily eye score monitoring. In grade 2 and 3 you will give IV dexamethasone, 10 to 20 mg 10 to 20 mg every 6 hourly, and for grade 4 you will give methylprednisolone 1 gram pulse therapy for at least 3 days, and grade 2 onwards um, we try to keep the patient in ICU. So this was all in general about ICANS and I score. Thank you.